Good morning, everybody. I'm going to call this meeting of the Anchorage Assembly Health Policy Committee to order. Thank you, everyone, for being here. Let's go ahead and have members go down the dais and introduce ourselves, and then we'll go to the members on the phone.
Joey Sweet.
Felix Rivera.
Robin Dern. Exalto.
And I'm Daniel Boland. And then on the phone, I believe we have Austin Quinn Davidson.
Yep, good morning.
Thank you. Christopher Constant.
Yes, good morning as well. Hello.
Kevin Cross.
Good morning, everybody.
And Suzanne LaFrance.
Hi, Suzanne here.
Great. Okay, we do not have any unfinished business, but I would like to make some updates to our agenda this morning. First of all, after we hear our standing report from the Anchorage Health Department, we will have an introduction from a member of the Anchorage Equity Committee who would like to introduce themselves and talk about briefly the work that that committee is doing. And then item C, under new business, we're going to bump to the next month due to some scheduling conflicts. So we will hear from the Providence team about their crisis stabilization programs in March. And I believe, do we have anybody here from Remote Area Medical? Okay, so you're going to be, after we hear from Salvation Army, we would love to hear about your free medical clinic that is going to be coming up soon in Anchorage. And so with that, I will turn it over to Ms. Rash for her standing report.
Thank you so much. All right, so again, my name is Kimberly Rash, and for the Anchorage Health Department update, these are related to December activities. The primary focus continues to be the development and placement of advertising, the Environmental Health Plug at 20 campaign, and we had the alcohol tax ACEs prevention grant advertising campaigns were underway. Development of the advertising campaigns promoting teen dating violence awareness, sexual assault awareness, tuberculosis prevention, WIC enrollment, and syphilis testing were also underway. The Get Moving Anchorage campaign continued with the Winter Sprinter Challenge for December, which encouraged participants to submit photos of outdoor adventures. December saw 7 participants within that challenge. Additionally, the Anchorage Opioid Task Force took place in early December. The project is on pause pending receipt of the opioid settlement funding needed to fund this task force. So we are working with OMB and the CFO's office to locate the funding for this. The Anchorage Safety Center. Overall, 284 individuals utilized services of the Anchorage Safety Center more than once, thus creating 477 intakes or occurrences due to the multiple visits in the month of December. For Environmental Health Services, the program addressed 73 complaints in December. They performed 83 inspections, made 545 customer service contacts, renewed 46 liquor and marijuana retail licenses, responded to 4 foodborne illness reports, completed 6 and worked 2 plan reviews, and issued 49 permits and administered 7 food worker cards. For our Women, Infants, and Children program, or what we like to call WIC, the Family Service Aid was hired in December and is starting in January. WIC purchased 30 boxes from Arctic Harvest Deliveries with alcohol tax funding, which provided to participants on a first-come, first-served basis. This event took place on December 6th and 13th, and with 15 boxes provided at each event. Johnny's Produce will be accepting fresh bucks in partnership with the WIC program. In December the 21st, 27th, and 28th, WIC provided fresh bucks to eligible participants at Johnny's location. A total of 246 fresh bucks vouchers valued at $10 each were issued to 83 participants. The Anchorage Neighborhood Health Center liaison visited WIC in December, or on December 14th, to meet with the team, review the partnership process, and answer questions. And then the new protocol is expected to roll out in January, wherein Anchorage Neighborhood Health Center will help applicants complete WIC applications. The formula shortage continues to affect WIC participants. The USDA declared they will not extend waivers to purchase formula outside of Abbott's contract after February 2023. This may affect the participation enrollment rates since WIC will be the only permitted to provide prescriptions for Abbott products. We have 2 vacant registered dietitian positions within WIC. They completed 4 vendor visits, which were completed in December. Several issues were identified, such as WIC stickers not being placed in the correct location, the wrong food being identified as WIC, not enough WIC product on the shelves. One store didn't have any WIC stickers. And so some of the managers and staff were not adequately knowledgeable of the program, and managers were not receiving or sending out notifications to their staff about the WIC from state as required. And so this process, our WIC program manager and the state have collaborated and are working together to address the issue. So there's going to be more monitoring, there's going to be more education with stores, local stores, to get them back up to speed. Within our WIC breastfeeding peer counselor program, we have 2 staff members providing breastfeeding support to 106 women currently enrolled. WIC is recruiting for more peer counselors through Facebook and Instagram with the job announcements. We had 240 total contacts were made in December to the 106 enrollees, 28 Facebook posts with 15 Instagram posts in the month of December. The Facebook page reached 2,343 people in the month of December with 4 new followers. On to SNAP-Ed. So this is slated to start again January 23rd. Community health nursing, so we continue to provide immunization records and COVID card replacements. We tracked 2 cases. There were siblings of varicella, which is chickenpox, and investigated the enteric disease in partnership with the state. Our clinic provided 146 routine vaccines, and so they're sort of listed out in this document. Our sexual health clinic, STI Express Services, is a walk-in screening following specifically on STI screenings of low barrier, no cost. We offer those on Mondays. 80 clients were seen at the STI self-referral walk-in clinic between the ages of 15 and 65. And we only had 4 positives, 3 for chlamydia and 1 for gonorrhea. HIV prevention, we completed 11 rapid HIV tests, 4,500 condoms were distributed at various locations citywide, including our own location. Our teen unintended pregnancy prevention, they had a busy fall semester with 17 presentations to 12 cohorts of youth, totaling 282 youth in 8th grade at 3 ASD middle schools. And so they received positive feedback from the youth and from the teachers. Thank you.
Thank you, Ms. Rash. As always, the Anchorage Assembly appreciates the hard work that the Health Department is doing. Do members have any questions for Ms. Rash? I'm going to go to Member Zolotel first, and then if members on the phone want to text me to get in the queue, feel free.
Thank you, Chair. So a couple of questions, and one is actually for the municipal manager as well, since he's here. What's the current vacancy rate for AHD, and what is the vacancy rate specifically around division directors? How many are filled and how many are vacant?
Okay, so the report that I had provided had the year end, so it was still at 24% for December. And then did you want me to answer the next question? Or?
Yeah,
Okay.
I know the division director breakdown right now. How many are vacant, and how many are there? How many are vacant? How many are filled?
So we currently have at the executive leadership level, we have currently vacant the director's position, human services division manager, the PIO, public information officer position, and those are the only ones currently.
Okay, those are the 2 vacant ones.
Mhm.
Okay, my question for the municipal manager, if there's any update on the director search for the health department, if we had any luck, what's going on? I know we are looking to or need to extend Ms. Rash's appointment potentially as the acting department director, so just like to get that information.
I did receive an applicant from HR, it was earlier this week or last week. I have not even had a chance really to do anything of that.
Okay, fair enough.
But yes, we do have at least one applicant we need to take a look at. We do have an applicant we need to look at. Thank you.
Okay, Blair, you want
Through the chair, Ms. Salatel, I believe you're correct, and I'll look into
getting an extended acting assignment on the addendum before I go.
Yeah, thank you, appreciate that. Thank you, Mr. Chair.
Okay, thank you. I want to acknowledge that Member Solt joined us at about 9:17 a.m. And then next we will go to Member Rivera.
Great, thank you, Mr. Chair. So my question is for Ms. Rash. Do you have any updates on some of the food security issues that we know many residents are facing, primarily due to the state? In particular, the Anchorage Equity Committee is interested in this topic. So could you speak to the role that the Anchorage Health Department has or not working with the state on this issue?
Yes, most certainly, thank you. So currently, we do not have a role other than, trying to look for solutions to help our community. Excuse me. I did speak with Deb, who is the director at DPA yesterday, and asked her, was there any other updates? She did say that the commissioner was speaking yesterday between the 3 and 4, and that they did post that on their Facebook page for the updates. They do have an updated FAQs document listed, and just encouraging people to not continually reapply so that the application that they did submit can be worked. And that she is open for any feedback that the Assembly may have. And that if there is anything that we can do as a community, she's more than happy to partner with us and we can partner with her as well. And that was the only updates I received yesterday.
Okay, thank you. So it sounds like there are some messaging pieces that we could put out to help the state with this. All right, thank you.
You're welcome. All right, we've had Member Perez Verdia join us at about 9:28 a.m. And next in the queue, we go to Member Quinn Davidson.
Thank you, Mr. Chair. I was curious, Ms. Rash, about your statements about formula. I didn't realize there was still a shortage, and I'm wondering if you could just talk a little bit more about that and maybe fill us in a bit. I'm literally feeding my baby a bottle right now, so maybe that's top of mind. And then second, you and Kent had both put together a document around alcohol tax funding that you wanted to put a package forward, I think, at our next meeting. And there has been some email traffic with me and Mr. Rowland back and forth. Can you just speak to that? If it's okay with Mr. Chair, if we could just speak to that and kind of resolve it so we can go ahead and get that introduced.
That works for me. Go ahead, Kim.
Okay, so in regards to the WIC contract that they have with Abbott, it is affecting us. It is affecting a lot of health departments across the United States. Our state partner and our WIC program manager are trying to work very closely to see what we can do. But at this time, the product can't keep up with the demand currently. Abbott did have a few issues that we've seen in the news in regards to their formula, so that created a backlog. So we're trying to look at options and work with our state on that. So it's currently underway.
And then,
So Abbott is a producer of formula. Oh, sorry, Dan.
I was just going to say maybe a little bit of expanded context when you get to your second question, if you want to provide that.
Okay.
So,
And just
members,
quickly,
go ahead.
so Abbott is a producer of formula, and we're just having a hard time getting it from them. Are there other producers?
Yes, there are other producers, but the federal government has a contract with Abbott directly, so that is the only prescription that we are allowed to give out to WIC participants. But there are other brands out there of formula.
Okay, well, let us know if there's anything we can do. I don't understand the regulatory framework well enough, but let us know if there's anything we can do on the assembly level.
Will do, thank you.
Austin, did you want to speak to
Okay,
your second question on the alcohol tax funding?
Sure, I can describe it a little more. Yeah, so Kim and Kent had sent Dan and me an email suggesting that they put forward a document appropriating really a comprehensive package for a lot of the prevention work associated with the alcohol tax. But I had asked some questions in the email thread, and I think some got resolved, but there's still some outstanding. So is this an item that was consistent with our FY23 budget? And I think Desiree confirmed that it was. But I guess any other information you can share. Is there a public hearing? I didn't think so, but you mentioned that a prior document had been brought forward. So if you can just sort of fill us in and we can have a short conversation about it, then I think when you bring it forward to the body, we won't have to have that conversation at the diet.
Excuse me, hello, Member Quinn Davis, this is Kent Coldays. We plan to bring that AM to the body next week. It'll be on the addendum. I would honestly have to look back at your email and see what questions you had that we may not have answered. We should be able to provide answers to those, but our intent, it was on the agenda for either the previous meeting or the meeting before that, and or it was in my queue and on base, and we didn't move it forward because I and others had some questions about it. So we can look at that this afternoon. My goal right now is to have it on the addendum for the meeting next week.
And I wonder if you might email all members about that, just so we can all be kind of plugged in.
Yes.
Okay, thank you, Kent, appreciate that. Okay, let me
Yeah,
check my,
and can I quickly,
go ahead.
Dan, just say maybe what the questions are? So is this consistent with the budget we passed? I think it is, but if you can agree with that as well, that'd be helpful. And by the way, there's an echo, so if someone can turn their mic off, that would be really helpful. Thanks. Oh, it went away. So peaceful. Yeah, so, and then is there a public hearing? I didn't think so. That was the question when you were going to lay it on the table, was whether, folks were going to have a chance to comment on it. I think as the addendum, there's a little less concern about that. But those were my main questions surrounding it. So not that complicated, but yeah, if you want to email us, that's fine.
This is Kent again, Austin. We will get you the answers to those questions, but I believe it is consistent with the budget that was passed, and a public hearing would not be required.
Okay, next in the queue, I'm going to go to Member Rivera.
Oh, sorry, Mr. Chair, I'm not in the queue.
Okay, and then I'll go to Member Zolotel.
Thanks. So why wouldn't a public hearing be required if it's for $4 million or something? Like I heard a large amount, or it was for a large enough amount of money is what my understanding was, because it was a comprehensive package. Is it? I may have the wrong amount, so sorry about that. So I think we need to make sure we verify that.
Through the chair, Ms. Saltel, this is Blair Christensen. I will talk with Ms. Rash and we will look into it before the meeting.
Great.
Okay,
I'm so sorry, Mr. Chair. Can I ask one more question?
go for it.
Another thing I had raised is, and if someone can turn their mic off, please. Another question I had raised was that one of the line items was for the coalition, and I had asked you to please separate that and bring two different items so that Ms. Salatel could vote on the bulk, the remaining items. So if you can do that, that's a lot more efficient than us trying to bifurcate on the floor. So just putting that request in. Thank you. Sorry, Mr. Chair. Thanks for the time.
Okay, thank you. I think that's all on that item, and we will move on in our new business here. And next we will have Ms. Agnew Beck from the Anchorage Equity Committee introduce herself. And you can just go ahead and come up and get on one of those microphones there so we can all hear you loud and clear.
Morning, everyone. Sorry, I know it's confusing. My business's name is Agnew Beck, and my personal name is
My
Thea
apologies.
Agnew Beck.
My apologies.
I like to keep the life-work balance. Yeah. Great. And I'm not here as part of Agnew Beck today, which sometimes I am. I'm here today as one of the volunteer community co-chairs of a newly formed Assembly Committee. It's the Anchorage Equity Committee of the Assembly. And this committee, just a little bit of history, formed actually the people who are on it came together in February of 2021 to advise the health department around vaccine allocation during the COVID pandemic. And met monthly, was a great committee, did a lot of good work with the department, really made measurable differences in terms of making sure we got vaccines out across the community and making sure we addressed race-based disparities in the impact of COVID. So it was very successful. At the end of 2021, the health department decided they didn't really need that committee anymore, but the committee really wanted to stay together. And so with the help from both Assembly Member Perez-Verdia and Rivera, we kind of kept meeting sort of informally on a monthly basis this year and developed a charter, which I can leave with you some copies, and it's also up on the website if people want to consult it. And then started the process of becoming a formal committee of the Assembly. And so in October of last year, that process was complete. So we're different than all the other committees because instead of having Assembly members as the committee members, we're almost all community members, and we have both members Rivera and Perez-Verdia as our liaisons. So they're there as well. And of course, all Assembly members are welcome to any and all the meetings as are members of the public. We have about 30 people that are on our roster. Our process for adding new members is pretty frequent. At any time, any member can bring forward the name of somebody who'd like to join, and as long as the rest of the committee agrees, that person can become a member. And then once a year, we'll be renewing our membership as well as electing new co-chairs. So this year, I'm one of the co-chairs, and so is Pastor Leon May. So we're the two co-chairs. And just a tiny bit more information about us that you can also find again in this charter. The purpose of the committee is to advance equitable outcomes by advising the Assembly's planning, policies, legislative work, budgeting, and programming, to empower equity leaders to advise the Anchorage Assembly, and to intentionally engage people with lived experience of inequities when advising the Anchorage Assembly, to ensure the needs and priorities of communities most impacted are centered in policies and budget. And then just a tiny bit about our scope of work. Some of the things we've identified so far, but these things could change, would be to really help center equity in the Assembly's strategic planning and priorities, helping develop tools to monitor equity, helping to make recommendations around community needs and priorities, advise on the agenda, advise on the budget, and advise on goals. So it's pretty broad right now. We had a planning session on Saturday to really come up with our annual plan, and one of the first things we decided to do was to make sure members of our committee were joining every other Assembly committee and just introducing ourselves in the committee to each Assembly committee. And then from there, we'd love to talk further, as we get our feet under us about how to work together. So we're in it for the long haul and ready to figure out the best way to kind of integrate into the existing structure.
Fantastic. Sounds like you all have been doing some really good work. Member Zolotel has a question for you.
Yeah, thank you. And maybe it's a question to take back and come back with an answer later, but how do you plan to make recommendations to us or to various other committees? We're used to resolutions, but you have a different structure.
Yeah, and that was one of the main topics of our planning session on Saturday. So right now what we've come up with is first to do this round of kind of introductions, just so we all can put a face to the name. And then probably what we'll do is a combination of three things. One, we'll probably assign members of our committee to attend the other committee members, or the other committee meetings, just probably as a member of the audience, or at the table, however you want to do it, just to be kind of a liaison between the other committees and our committee. We'll also be, again, after we get through this first round of introductions, inviting committees to come to our committee meeting to get a little bit more in-depth discussion about what are some of your priorities, what are some of the topics you're working on that maybe would be useful to have our committee's input. And then the third way that I think we'll probably proceed is that we'll have the co-chairs, and probably not always the co-chairs, but other members coming to the Assembly main meetings once a month to give a brief report the way that the other committees do. So that's kind of what we come up with. And then as well as coming up with our plan and priorities, which we'll be, of course, sharing with the rest of the Assembly.
Thank you. I appreciate knowing that. Having written recommendations that we can put into the record, though, I think is maybe something to consider, just if you're supporting a particular path, because we often submit those, through assembly memorandum or information memorandums. So,
Okay.
like, for example, the Budget Advisory Committee, they make a resolution on whether or not they agree with the budget or have, different recommendations, and we take those into account, and it becomes a part of the record.
Okay, that's good to know. We can work with our 2 liaisons to do that over time. Thanks, that's a good suggestion.
Okay, any other questions before we move on? I don't see anybody from the phone. Thank you so much for being here.
Thanks. I'll leave these to our case committee ones.
Wonderful. Okay, our next topic is going to be a path forward on 24/7 mobile intervention team and mobile crisis team implementation. If I could have representatives from the MCT who are here, or from Fire Department, IAFF, and then Chief Curl. Is Sean here? Oh, Deputy Case.
We'll sit next to you.
Okay. There he is. You were hiding back there.
I'm present if you have any questions.
Yeah, I would go ahead and take a seat there. Thank you all for being here. We would like to hear an update, and I think we'll probably start with the administration on a path forward for our 24/7 pilot of the MIT and MCT integrated model.
Thank you, Mr. Chair. Kent Colhays again. Unfortunately, I don't think I have the update that the body's hoping for. I did email some of you yesterday. I've been challenged on my part in finding time to meet with Chief Earl and his team, with Chief Schrage and his team. I was able to last week to sit down at Ms. Christensen's strong insistence, sit down with her and get an overview of the MCT and MIT program and the planned path forward. I've talked briefly, I guess, with Chief Schrage and Deputy Chief Case. I haven't had, Chief Curl and Deputy Chief Case. I haven't had an opportunity really to sit down at all other than about 5 minutes yesterday with Chief Schrage. So I'm aware generally of the plan. I do know that that there are some positions that both Chief Schrage and Chief Curl have been moving to hire that are in the HR process right now. And I'm going to reach out to the HR director this week and see what we can do to move those through the classification process. And I think that those positions will go a ways towards helping increase the coverage. I would say right now, I don't know what it takes to provide 24/7 coverage in the way of staffing.
Okay, I'm going to go to Member Zolotel because I think she has a list of questions.
I do. So just for a little bit of background, for anyone who's tuning in to this conversation now, myself and Ms. Quinn Davidson worked really closely with Ms. Christensen and the former municipal manager to come up with this integrated model that leveraged both APD resources and through the mobile intervention team and the mobile crisis team. The mobile intervention team was provided 1-year funding, and the mobile crisis team has basically become an operationalized portion of the alcohol tax budget. It's expected to continue year over year. And the hope was to have 24/7 coverage very shortly. And so I have a couple of questions. One, have there been conversations about the dispatch implementation? We talked a little bit about the Fairbanks model, which has kind of a spectrum of different call types and then dispatch according to those things. One of the things we talked about was conversations between APD, AFD about how that would be handled, and so that it could be transparent. We could then be talking to the public about what to expect when you call, knowing that there's a risk assessment made on the other side by dispatch. And so I would like an update on that.
Through the chair to Ms. Zolotel, I believe Deputy Chief Case is the person who has that information that would be able to best answer that question.
This is a little bit of a long-winded answer to your question, but so we've implemented, and I think both NCD and MIT have looked at kind of the 5-step response model, keeping in mind that, again, most of the calls for service generate through the 911 or the 311 phone system. So the data that we collect is going to be a lot broader, just because that's where the calls generally come into. So currently what we are looking at with our current data, because we want to make sure that we have that stuff prepped when we do have MCT and MIT expanded, is we're looking at those 5 different categories. We are not only looking at the calls, how they're dispatched, but then when the MIT, MCT officers who arrest contact with those callers, how they're disposed as well. So, for instance, a level 1 call, we may have, let's just say 20% of the calls are dispatched as a level 1, and we look at it post-incident and say it's actually 15% of our calls ended up being a level 1 call. So those systems are already in place, on the APD end, and we should be able to report those numbers to you regularly.
Great. Is there any way to get where you landed on the response levels? Because we don't know what those are. Fairbanks publishes theirs, because I think we need to be able to talk with the public about how this works, because it's new. Or it's not new, I guess. Mobile Crisis Team has been on, but now we have the MIT component more specifically, and it's soon to be expanded. So I think that's going to be an important component to talk with the public about. So my next question is, where are we held up? I mean, this feels like we're on a bit of a hamster wheel, which is my favorite place to be, it seems, on some projects, because both APD and AFD are 24-hour operations already. It's built into emergency response, and we've been at this for about a year now, it feels like. We've heard the classification issue previously, and now we seem to be back to the classification issue. We passed the budget in November. Classification could have been started towards this. So how do we get to this 24/7 need? And I'll just preface that with, the need is now. We are amidst a community-wide behavioral health crisis. We see it on our streets. We see it a lot of places. So how do we catalyze this? What can we do?
Through the chair to Ms. Alatel, Christensen. So I believe that the classifications for both sides have been in classifications. Normally the classification process is a 6-month process, but our intention was to shorten that to a much shorter time period when we knew that the funding was approved. And so I have talked to Mr. Colhase about ensuring that HR pushes that through, and my hope is that sometime in February the positions will be up and running. Does that answer your question?
Up and running is one thing. We still have to find the talented people who can fill the positions. That's going to be the hurdle I think we're going to face. Once we get it through classification, we put the job postings out on the street, finding enough people to fill both MIT and MCT, hopefully it won't be a problem, but to find the talented, qualified people we need might be the hurdle that we don't have control over. That's where the stall is going to be.
I appreciate that. I have one more question, Mr. Chair, if that's fine. I'd like to know a little bit about the call demand coming into the mobile crisis team. Are you able to meet the demand? What's happening when you can't meet the demand? Just kind of give us a little bit of a briefing on that, and if you could remind us the hours you're currently under operation. Thanks.
Through the chair, Mike Riley, program coordinator for the mobile crisis team. In 2022, we ran right around, let me just get you good numbers here, 1,918 911 calls. So these were calls that went through the 911 call dispatch center, transferred to AFP dispatch for dispatch of the mobile crisis team. We also did an additional 614 post-crisis calls. And our goal is to, for every crisis call, we'd like to do a follow-up. With our current staffing and the call volume increasing, that disparity is happening more. We're not able to get to about 1 in 10 now, where before it was probably 1 in 5, 1 in 4. So the call volume is increasing. And that's a really good thing. That means we're available for the community when they're in crisis. We're just missing that follow-up component, and that's the important part about having that role of the referral specialist or social worker. I'm not sure what it's being called right now. That's that role, that's that gap that will be filled with that position. So right now we're 10 to 8, and it's not uncommon for us to come on duty at 10 o'clock in the morning and have a call or two holding. And that's a really good thing too. So what's happening is the community knows MCT is available. Person goes into crisis, they ask for us, and they are willing to wait. It's humbling, really it is, right? They want our service, and they're willing to wait for it. So it's not uncommon for us to come in for calls holding, or the call taker say, hey, we understand this is the best resource for you. This team's available at 10. Would you want to hold? And oftentimes that's the case, and if not, it just falls back in the system how it's handled today. We are not able to meet our demand. We're constantly in stack. I don't have the numbers on how often but our response times are right around 30 minutes right now. In the beginning, a year and a half ago, they were about 8 minutes. So that means we're always available. And when we saw longer response times, that means we're not available right away. And so it's taking us longer to get there. We're still meeting our 1 hour goal. That was always our goal. It's never taken more than an hour. But that's getting harder and harder, and it doesn't happen every time. And so what we've done as a gap placeholder, or a gap to fill a gap, we now call right away and make contact with the person requesting our service, and just let them know, hey, this could be longer than an hour, do you want to wait? And give them that option of, we're still gonna come, it may just be a little longer, and overwhelmingly they say, yes, yeah, we're willing to wait. So we can have hour and a half, 2.5 hour response time sometimes, if that person is willing to wait. That's not our preference, that's not our goal. Our goal is to get to them as quick as possible, but if that individual prefers our service, they're willing to wait, so that's a really great thing too.
So one of the ways we hope to, create more flexibility with the mobile crisis team in particular was to not necessarily require a EMT firefighter. So I'd like to ask IAFF and then maybe Ms. Christensen or Mr. Colles, where are we at with that idea of being able to bring on just EMTs for purposes of the mobile crisis team?
You first.
Yeah, Nick Lorioso, president of the Firefighters Union here in Anchorage, through the chair. So IAFF is ready to sit down and hammer out the details of this position at any time. We voiced that through our administration, that if we're looking to implement a new position within the fire department, then the bargaining unit is ready at any time to engage in that conversation. We believe wholeheartedly in this program, and I think the IAFF is not an obstacle in getting something done as far as negotiating a new position or creating a new position in the working conditions that position would require. So from our standpoint, honestly, we're just waiting to have the conversation. We've voiced that we're ready, willing, and able to have the conversation at any time. So I don't know if that answers your question, but
Through the chair to Ms. Alatal. So obviously we've had some transition since we've discussed this, but I will say that previously the direction was that we were not going to create a new classification that was an EMT only. I have not had the opportunity to speak with Mr. Colhes at length about this and if there's new direction, but I will say that my understanding internally was that the administration had decided that they did not want to create that new classification.
Thanks for that, Ms. Christensen. That's surprising to hear because the appropriation specifically called out the opportunity to do an EMT only option. And it was discussed extensively with the former municipal manager as we worked forward to have an agreement. So when there are changes of position or unexpected things that are contrary to what we appropriate because you either don't believe it can happen or you are choosing not to go that route, it would be really good to learn about those things as soon as you are aware of them, because it probably will entail a follow-up conversation because we want to understand why. We also want to understand why, in this instance, in the context of what we've been hearing from AFD around their challenges to get firefighters. We already know we're understaffed, so we also know we can use possibly just an EMT, not an EMT firefighter, to carry out this option and to try to be flexible to get this 24/7 rolling. So yeah, let's make sure this is my request, to keep those lines of communication open. It seems that in this instance, trying to implement MCT and MIT 24/7, we're always the last to know. And that's really disheartening because this was created at our impetus and we put a lot of time and effort, and it's a very high priority, I believe, for most Assembly members. Thank you.
Thank you. I'm going to go to member Austin Quinn Davidson next.
Thank you, Mr. Chair. I just wanted to join in with Ms. Alatel expressing sort of can everyone turn their mics off, please? Thank you. Just expressing my disappointment and dissatisfaction with this process. I mean, this was voted on to start July 1 of last year. So we're, approaching a year now. This is something other communities are doing. This is not that complicated. Blair, we've met with you. We've talked with Amy. We've talked with Colby. We have tried to help you guys get there. And I'm sure it's frustrating. I'm sure with constant turnover and Amy gone and Kent overwhelmed because he's one of few competent people left, it's challenging. And I'm sorry you're in that situation, and I'm sorry for our community. This is something that people stop me and talk about all the time. People love this program, and the Assembly loves this program, and we found funding for it. And you're keeping it from being implemented, and it's just really, really sad for our community. And I'm embarrassed, and I hope that you all can figure it out. Thanks.
Okay, thank you. I don't see any other member. Oh, I do have one member in the queue. Member Constant.
Yeah, I just want to join in what was stated by both members, also Ms. Quinn Davidson, and offer that I don't actually think this is an issue of complexity. I think it's an issue of will. Thank you.
And then we're going to go to member Zalatel, and then after that we will move on to the next topic.
Thanks. I have a request that as we move through the classification process for the clinician positions, they move together. I don't want APD or AFD to get out in front of one another. I think that the way this was planned was these were supposed to be complementary, concurrent programs coming online. And I really want to make sure we keep them as equal priorities moving forward. And I'm going to say that this is probably going to be a standing item if the chair will allow it on the agenda to make sure we know what's happening, at least with the classifications, so we can keep moving through the implementation and then checking in on the hiring process to see how we can support that. Thanks.
Through the chair, if I may.
Please.
So I will, as I said, I will talk with the classifications folks and the director of HR today, and we'll provide you an update. What I want to find out from them is the relative status right now with respect to the APD positions and the AFD positions, and see if one is further along than the other. We'll provide that information, and I'll emphasize the need to move these along, both of them, very quickly.
I appreciate that, and I will just make a final note on this topic that, this integrated model is a huge priority for the Assembly. It's a project that has, the Assembly's been working on for a long time, and I hope we capture a lot of this conversation as we may be preparing to go into more transition time in the near future. So whatever we can do, particularly Blair, to get as much information as we can that you can leave behind for a person who will endeavor to fill your shoes. Which will be a hard task for whoever that person is. Okay, moving on. We're gonna thank you all for being here. We're gonna go to the Salvation Army Substance Misuse Treatment Program update. So I would invite the members from the Salvation Army who are here up to the dais. Thank you for being here. Okay, so why don't I ask you to go ahead and introduce yourselves and let us know who you are.
I'm Lieutenant Colonel Doug Tollerud with the Salvation Army.
Hi, good morning. I'm Chris Pierce, the Business Administrator and Quality Assurance Manager for Cliff Center specifically.
Good morning, Ruth Hayes. I'm the Executive Director of Development for the Salvation Army.
Okay, wonderful. So I think what I would like for you to present is just an update on your various programs. And I know that there's particular interest on the 48th Street location.
Well, presently, the Salvation Army, since 1947, has operated the Cliff Row Center. In 1974, we occupied Point Warrentoft. Dr. Ray Dexter, for 25 years, was the executive director. That was multifaceted then, and it is multifaceted now. I believe it was about 11 years ago that we split the income from a fully state-funded grant to now where we have a state grant and Medicare reimbursement. It's a clinical program. It's a 3.5. What we are looking at and what we're finding out is that 48th Street, 660, used to be a social rehabilitation center for men. And there was 65 beds. The earthquake and a couple other things closed that. And so the progress is we do have a contractor. We do have the contract down in our legal department, and we'll be moving forward in the next 30 days, beginning the process of rebuilding that facility to hold 65 men. The goal is to continue funding. As you know, everything evolves. The Medicare 3.1, which would be those who graduate from the 3.5 for a period of time that don't have homes to go back to, don't have family members or jobs, will be able to transition into the 3.1, which will allow us another 30 to 90 days to transition them back into our community, into safe, productive environments. So that is where we're moving forward with the 660 facility. We also have, if you remember, our old home for unwed mothers on 20th Street, which is on Alaska Mental Health Trust property. We are also going to be transitioning that 30-bed facility into, we believe, if, again, our program people down in Los Angeles agree, to a women's 3.1 facility where those who in our women's program at 3.5 can transition into a 3.1 as well, because as we all know, they're transitioning back onto the streets and again, getting involved in the substance misuse lifestyle again. And so if we can hold on to them another 30 to 90 days, we believe that we will be more successful in the transitioning of them into a healthy life.
Thank you very much. And the other members like to speak?
I just wanted to mention, we do have right now 3.5. The 3.1 would be the next step in our continuum of care because we already provide outpatient services for people who do have housing, but that housing piece is probably the biggest problem for any of our clients moving from the residential into community. We currently have 2 clients out of Insight who have been extended for over a month because they can't find a step down or a sober living space. So we're happy to extend them, but at the same time, this comes up a lot. So having that 3.1 is very important for the community in general.
Ms. Hayes, anything to add?
I would just say we're grateful to the community. We have many partners that are helping us to realize the success in these programs, and especially the Alaska Mental Health Trust, the Rasmussen Foundations, and others that have come alongside and provided funding.
Wonderful. Okay, with that, I'm going to go to the queue. I have Member Zolotel.
Thank you. Just we have some new membership. Just for a little bit of context, and why we're asking about the 48th Street in particular. The Assembly made an investment in, I believe, with the design of getting that facility back online, or trying to expedite that after the earthquake, and as a part of the prior facilitated process on homelessness. They had some state funds to, I believe, help in the renovation. I'm jogging my memory here a little bit, but we wanted to make sure that those design plans could get moving as quickly as possible. Thanks.
Thank you. Then I have Member Rivera.
Thank you, Mr. Chair. Yeah, I'm excited to see that there is I think if I heard you correctly, a 30-day timeline to getting that facility open. We've been tracking this for, I think, what feels like forever, and so glad to finally see it opening soon. We've talked about this a little bit in committee before, but could you just remind us, for those who don't work in this profession, the difference between 3.5 and 3.1?
This is Chris. I can answer that question. So we follow what's called the American Society of Addiction Medicine ASAM criteria. A 3.5 is at least 20 hours a week of treatment activities provided by someone with either a CDC 1 or above in education and training. At a 3.1, because they are intended to go out and find a job, that requirement moves down to 9 to 10 hours a week. And then when you're in community, it depends on your level of need. Sometimes you're going to have more than 10 hours a week of treatment, and sometimes you're going to have less than 9. So 2.1 is above 10 or above 9, and 1 is below 9 hours a week. So you're working, you're living in your own home, but you're coming to groups and individual sessions with your counseling staff and other staff members. If that helps your question.
That does. Thank you.
Okay, and then back to Member Zolotel.
Thanks. So you talked about the step down that'll be available, I believe, at 48th, which will be about another 30 to 60 day time period. Are the majority of folks who will transfer into that project going to need housing, or will some maybe have housing to return to? Can you talk a little bit about where that will fall? Because the program itself isn't necessarily targeting individuals who are experiencing homelessness, I don't believe.
So to answer your question, 3.1 doesn't specifically target homelessness. These are services for people who have a substance use and sometimes co-occurring mental health disorder. 3.5 is you've come out of a detox or a very serious issue or crisis. You need 30 to 90 days of stabilization. We're going to teach you how to not immediately go to substances in order to solve your problems. Many of those clients are homeless or effectively homeless because their family won't let them back in until they stabilize. So the 3.1 then allows them to, all right, I've got some tools under my belt. Now I can look for a job that doesn't involve substances. I can figure out how to get housing that is within my means without maybe relying on my family members who have extended me a lot of courtesy and grace. So it, in the long term, could solve some homelessness. I'd say that maybe 10% of our clients are from a homeless community population, but a lot of them are DOC involved first and foremost. So they are effectively homeless because they're coming from a controlled environment where they have no community supports yet.
Okay, thanks. And the reason for my question is we're working on housing and housing solutions. If we're looking at a rotating basis of approximately 65, individuals who will need to find housing, I think that that's a part of the challenge that we should be aware of and thinking about. So, thank you.
Questions from other members? Oh, I do have Member Constant. Go ahead.
Thanks. Somebody brought my attention. We heard months and months ago that this project was ready to go, there was a plan set up within months.
You're sounding a little garbled.
I think someone needs to mute the microphone.
Hey, Member Constant, you're breaking up there a little bit, sounding a little bit garbled. Do you want to try it again?
Someone should mute their microphone. It's the echo. There we go. Is that better?
Yep, we can hear you. Go ahead.
Okay, so months and months ago, maybe a year ago, we heard that this was near implementation. And I'm curious how we're just getting to the point with the contract if the plan was to have this open in the end of last summer or fall, and now here we are hearing that it's not ready. We don't even have a contract yet. I'm very interested in an update on that part of the process.
Through the chair, Mr. Constant, this is Ruth Hayes. We have engaged with the architectural firm beginning last year when the Assembly was gracious enough to give us the $100,000 to address the design and codes and conditions on the building. That was completed as quickly as possible. Following that design phase, or the codes and conditions phase, we continued, I'll say back since January of 2020. We have been working with the Muni, at the time it was Nicole Lebo, who is now no longer with the Muni, to identify funds that were available through the state that were put aside for the Clitheroe facility by Senator, I believe it's Senator Natasha von Imhoff and Commissioner Crum at the time. This is 7 or 8 years ago, those funds were put aside. The Muni, when we had discussions when Mayor Bronson came on, was not even aware that those funds, at least the folks we were speaking with, were not aware that those were available. After extensive discussion, I mean months of discussion, we finally had a conversation that involved the municipality, Natasha von Imhoff and Commissioner Crum, and it was decided that the Salvation Army would be, the governor had decided that the Salvation Army would be the ones who received those funds to execute both the Clitheroe facility renovations and the 660 48th Avenue facility, because they were both Clitheroe-related programs. It's one transitioning to the other. So fast forward to May of 2022, the RFP was finally designed by the Governor's Office and the Department of Health and Human Services, which is now the Department of Health. It's been changed, they were separated. And we responded to that RFP. It's a non-competitive RFP, so it was just the Salvation Army that was responding. And that was a time frame of weeks. I mean, we had maybe 2 or 3 weeks to get that in, and they responded quickly. And we received an answer back in July that obviously it was going to be awarded and the funds were going to be disseminated.
Okay, thanks. Mute the mics again. Thank you. So I will just say that there are several of us who are aware of the funds and the sweep that happened and the redirection of those funds from the old site where there was an Alaska Center for Treatment proposal to this new site. But I think what it sounds like in effect is that once again, the loss of the kind of experienced leadership of the municipality has caused this project to languish. Thank you.
Go ahead.
Colonel Culver, through the chair. Would like to say that I have a little history with the Point Warrenzoff reality, dating back to when I actually was on the Community Service Patrol, clear back in 1975, when I was an EMT and in the military. So I understand the history of it. But through that time, the money that came to Clitheroe and the 2 sites is the fact that there was one time when the airport wanted that property for expansion. And so the pendulum has gone back and forth over the last 25 years of whether or not the investment was even going to be made in that property. By the way, the state funds will include half of it going to the remodel and freshening up of Clitheroe with new windows, new carpets, new paints, the Point Warrenzoff site. So it's not all being invested in 660. It's also going to be half invested in Point Warrenzoff to continue with that program until the powers that be decide what the fate of that property will be in the future. So we're excited about that.
Ms. Hayes, go ahead.
If I may, through the chair, Mr. Constant, the Salvation Army, just so you're aware, is apolitical. I just need to state that up front. We work very closely with the government. We work very closely with the governor, but to your statement that the administration was lacking or whatever, I can't quote what Mr. Constant said exactly, but I will say that the governor, the mayor, his administration, Adam Trombley especially, was extremely helpful in trying to move this money along. A major part of why it was held up was because of the split of the two departments down at the state level. And we waited for months for a check to be sent to us. It was our decision at the Salvation Army's level not to move forward on beginning the projects, either one of them, because we had to have the money in hand first. And it wasn't anyone's fault in particular, but I think the financial structure, I worked with the grant administrators very closely, and the governor was in their office many days to say, we need to get this check cut. And so I just want to make it clear that I think, Mayor Bronson especially was on the phone almost daily with the governor at one point. And when he was down visiting, would always, come back and say, we're moving it, we're trying to move it. And again, I think it was structural. The financial systems were not in place yet for the two departments. And that was what I was getting back from the grants administrators about that. So just wanted to clarify.
Okay, thank you. Did you want to follow up?
I appreciate that you assert political and then out of the next breath start defending the mayor, which is your right. But I can say that my reaction wasn't because of any of that. It was because it was an assertion made that people at the meeting didn't know where and why and how those funds came to be or moved. And I can tell you very plainly that that's not the facts. The facts are we did very much know. And then in order to, on the back end, create a rationale that your property is sufficient to meet the consent decree of ML&P, so we didn't need the Golden Lion, that was why they started pursuing that project. And so it's a fine argument to say any of that stuff, but my whole message was ultimately we did know about that money, and there's a reason why it took so long on our end. Thank you.
Okay, we're going to go to Member Zolotel.
Thanks. I think this goes back to the communication issue. When there are holdups and the assembly appropriates funds and, the Salvation Army project was brought as a joint effort between both branches of government, keep us in the loop. Just because you communicate with the administration doesn't mean we're hearing the communication as well, so it's an invitation. We have to stay in the loop because we answer to our constituents about where these projects are. I know the 48th Street, I don't know if I'm calling it by the right name, that's what I call it, the 48th Street project. It's really, Midtown Community Council welcomes it and they ask about it. And so we're asked frequently to provide those updates. So please stay in contact with us in addition to the administration. Thank you.
Thank you. And I don't think I have any other members in the queue, but I'll just say I appreciate you being here today and providing this update, and would welcome you at future health policy committee meetings to do exactly that, to be able to dialogue with us, and really supportive of the work that you're doing in our community. So thank you. I think with that we will move on and invite our next guest up from Remote Area Medical. Welcome. Will you please turn on one of those microphones and introduce yourself, and we are excited to hear about your project.
Thank you. A little closer.
Go ahead.
My name is Dawn Morse, and I am here. I'm a community member in Mountain View, This is my first time. I was expecting maybe 5 people around the round table, so this is a little bit different for me. I am, let's see, I'm here to talk about a project that can make such a difference for our community. I've got some notes.
Can I start by asking you a question? When is your clinic scheduled in April?
Yes, thank you. So I'm volunteering with the Mountain View Lions Club, and they are partnering with a group out of Tennessee called Remote Area Medical. We are bringing multidisciplinary healthcare services clinics to Anchorage and to Fairbanks in April. The clinic in Anchorage will be the 14th, 15th, and 16th of April. The one in Fairbanks will be the next weekend. And this is, for those of you who are familiar with Mission of Mercy, where they have like 80 chairs in the Denina Center doing dental work for, I think, 1,300 people for a weekend. It's like that, except it's not just dental. It's also vision and medical. And we are trying to also blend. Remote Area Medical has been, they've been doing pop-up clinics like this all over the country and internationally for, more than 3 decades. So they're real experts in this. They've done more than 1,300 clinics, and basically they are committing to bring us a pop-up clinic in a box. They have a tractor trailer full of equipment, supplies, and they have a team of 30 experts that know how to manage the clinic once we get the volunteers. And they're bringing somewhere between at least $300,000 to $400,000, basically, that they are just gifting Alaska, infusing in our community, because they charge us nothing for what they're doing. Mission of Mercy was huge, but they rented their equipment to that local group. And Remote Area Medical is just bringing it. They have a lot of donors that care. So, yeah.
Ms. Morse, I actually have a question for you from Member Zolotow.
So one of the reasons I'm happy you're here today is hopefully you meet Ms. Brash, who is the head of the health department. This seems like an opportunity for us to possibly cross-promote, have a conversation so that the municipal health department is aware of the plan and how we can leverage. I know AHD has a few mobile items as well. So that was really a big part of the impetus, so we would be aware of it and hopefully can make this connection. And as we heard in Ms. Rash's report earlier, they have a fairly robust social media. So I hope after the meeting you guys can connect. Thanks.
Yes, thank you. I noticed that too when you were doing your report. Ooh, there's a lot of alignment there, so totally agree with that. Let's see. There are also Remote Area Medical has a group, like a database with, I think, 13,000 providers all across the country. Many of them are also very interested in coming to Alaska. They pay their own way. They pay all their expenses to come and volunteer. So that's, we will have some support from out of state. Our recruiting goals right now, we still need about 180 providers in Anchorage, and then again in Fairbanks, and we need about 650 general support volunteers. And I have flyers, and this is like a sponsorship packet, right, that says, here's the need, which all of you know is a huge need. So we have we've been kind of building. I was brought in as Patrick Campaign, is a local optometrist, has had this vision since he volunteered for Mission of Mercy. He was very moved and he searched for the right organization to work with, and he went to a remote area medical clinic and felt like that was really the right connection. And so he has been working for at least 2 years to bring this into being. He brought me on, engaged me as a grant writer back in July, and I, in October, said, you need somebody really focused on recruiting, and so this is where I want to volunteer my time. It's been a lot of time. We've really met with a lot of groups. Everyone's very supportive. Part of the reason that it's important. Do I have a time limit? Am I going over?
Keep going, you're doing fine.
Okay, thank you. Remote area medical is focused on dental, vision, and medical. All of their years. Every single group that we have talked with, Anchorage Neighborhood Health Center, and Catholic Social Services, and Beans Cafe, and Alaska Regional, and the Providence Health, Population Health, and we've met with so many groups, and everyone says, and also just our own, I heard you say it today, we need behavioral health. We're desperate for behavioral health. And so what I'm also hearing is we don't have a perfect solution for that. There's just not enough resources. So I feel it's very important to wrap in a behavioral health component for these clinics. I'm not sure how to do that. And so part of I recognize that we can't have a complete solution. I don't think we need to have that. I think it's really important to just put a toe out there and to let people, the patients that come to this clinic, which are probably going to be 1,000+ people, to let them know there are people who care, that there's someone who will listen, who's compassionate, and here's a first aid kit for you to take out with you, right? A list of the organizations that maybe you can go to for help, right? It's not perfect, but first aid kit, keep that in mind, yes. Chair.
Because I don't have anyone in the queue, I'll ask you a question. It's more, or are you in the queue, Felix? Okay, can I come to you just a second? I just want to reiterate that the event is at the O'Malley Sports Complex, April 14th through 16th. Gotta give a shout out to my boy Patrick Campaign. Optometrists are doing a lot of cool stuff in this community. And how you're looking for volunteers? It sounds like more providers. How can they get in touch with you or your organization if folks do want to volunteer? What's the best way for them to do that?
Do you want me to give a phone number?
Is there maybe a website?
There's a website.
Yeah, what's the
Remote Area
website?
Medical is RAM, R-A-M, like the sheep, so RAMUSA.org. And at the top right is a red volunteer button. You tap that, 5 minutes flat, you're registered to volunteer, okay? For all providers, Alaska has statutes that provide immunity for people giving their health services, so there's no need for insurance.
Can I go to Member Rivera really quick to ask you a question as well?
Great, thank you, Mr. Chair, and thank you and everyone involved for organizing this. So I had a couple questions. First is, what is your target demographic here? Is there a certain socioeconomic spectrum that you're targeting for this event?
Thank you, Mr. Rivera. So our target demographic is people who are hurting, people who are falling through the cracks in the system. Many of us do not have insurance. For those who do have insurance, deductibles are high, and many people avoid care because they can't pay the deductible. or they don't have insurance for dental and vision. Remote area medical will have a lab on site. People will be able to come and get their vision checked and have glasses that same day. There will be 20 lanes for dental with restorative and extractive being 15, and then 5 lanes for hygiene. And then we'll have medical as well. And so this is, remote area medical has like one mission, and it's to relieve or prevent pain and alleviate suffering. And that's what we're trying to do here. So.
Great, thank you. I guess my follow-up for that is sort of understanding the target demographic here. Are there plans in place for helping to transport people to the O'Malley Sports Center? Because, just thinking about a lot of the people who would benefit, there would be people who maybe don't have access to transportation, and O'Malley Sports Center is a little bit out of the way for those individuals.
I am so glad you brought that up. So, for instance, the Downtown Hope Center is planning to just bring people down, right? It is on the bus system. I put that in quotes because there is a bus that goes to.
You gotta take like 5 buses to get there.
Right, it's so hard, right? So I will tell you that when Patrick said I've gone to 12, 15 places to try to figure out where to hold this clinic, right? And I said all over Anchorage, and it's so expensive at the Denina Center and Egan Center, and there's no parking, and I tried Sam's Club, and they're not responding, and he literally, like, I had him list out the places he tried everywhere. And I said, well, but there's one place it should be. I know exactly where that is. And it's Begich Middle School. Because there's parking right across the street at Fred Meyer and at Walmart. There's hundreds of places there. I'm sure they'll work with you. It's the heart of our community, neighborhoods all around that where people have a great need, right, for this. And it's right on the bus system. It's just, and it's so perfect. And how could, they just know that the ASD will just jump on board. 5.5 months with ASD. We walked through 5.5 months. We went through every single hoop with ASD. And the very last thing, they sent us an email that said, no, it's not risk management, and risk management says no. There was no explanation other than insurance and risk. And remote area medical covers insurance for the venue, and the expense, risk and expense. And we were offering to cover the cost. And so that didn't make sense. I said, could you please, with the community services, I believe is the name of the department, with the person that we had been working with the entire time, she said, speak with me only. And so we did, we respected that, we honored the process. And then it was a flat out no with no explanation. No, we have no further thing.
I just want to interject in the interest of time. I think the takeaway sounds like you have some people who are really advocating for this, and you were able to figure out a location, and although it may not be ideal, your event is able to proceed forward. So I think that is a win. Let us know how we can be supportive, and thank you for bringing this to our attention. One final question I would have, folks who do have insurance, does remote area medical bill that insurance at all, or is this a completely free clinic?
Thank you, it's completely free. There is no ID required. There's no questions asked. There's no insurance billed. Everyone is welcome. It is first come, first serve. I do have one request of the assembly, which is the remote area medical staff that's coming. We are responsible for paying for their lodging. There's 30 people. And we have Spring Hill Suites, but there's a 12% bed tax. Is there a possibility of waiving the bed tax for that? Because we are on a shoestring budget, so I would ask for consideration with that.
That's an interesting idea, and we will look into it. Thank you for
so
being
much.
here. You bet. Okay, we've covered a lot today. We'll move on in the agenda to our committee legislative and budget priorities. I don't really think we have any items there under those topics, and so go to members. I'll tell you when to add something.
So I have something that may affect the 23 budget. So, and this will be for you, Ms. Rash, that you may have to come back and tell us more about it later. But with the number of vacancies in the health department, I'd like to take a look at our billing for insurance, Medicaid, Medicare, and kind of our reimbursement rate. I know it's built into the health department's budget. And if we don't have certain positions, I think we might lose the capacity to do some of that billing, particularly, at the higher clinical levels. So maybe we can work together to kind of figure out what the right mechanism is to investigate that. But I think we need to be aware of any impacts that may be having before we hit first quarter.
Okay, yeah, we can get together.
I think Member Constant has a question for.
Sorry, for
Go ahead.
Daniel, Mr. Chair, my question is for a different presenter, Ms. Rash, before the meeting ends.
I think now would be that opportunity before we go to audience participation.
Okay. Great. Kim, one thing that I didn't ask before, it just slipped my mind and then popped back up, is a conversation about the safety center. Two things. I'm interested in a future meeting having a discussion about the downward trend of the usage of the sleep-off center from, say, 2014, 2015, 2016. That's a pretty substantial change, and I would love us to figure out why the numbers are down. And I'm guessing I have a couple ideas, but I'd rather have a database conversation. And then the second piece is, there was a very concerning video relating to the safety center, and while we don't need to get into too specific information, I sure would love to have a short briefing on the status of that.
Thank you for that. So the Anchorage Health Department is still investigating, working with Anchorage Safety Center, receiving their written documentation, also working with their legal department, looking at the contract as well. So it's still underway right now, and once I know more information, I will communicate that across.
Good. Thank you very much. I just wanted to make sure that marker's on the table.
I think that might be a good topic for our agenda for next month as well. Okay, with that, we're going to move on to audience participation. Are there any members of the public who wish to participate? I am not seeing any. I would entertain a motion to adjourn. Or adjourn.